It's great to be here and in Manchester, and thank you for putting such a good program together. Now, paravalvular leaks, and what our objectives are this afternoon, the next half an hour, is to just look a little bit at how often does it occur. Is it, we know sometimes the surgeons ask difficult questions. They say, well, what is that little flash you see there? And then you have to think on your feet and make a quick decision on, this light is very bright. Can I think? In any case, make a quick decision on whether they should go back and repair that paravalvular leak or whether we can leave it safely and have no complications afterwards. So we're going to look at that. And then the factors predisposing to this. Some patients, it occurs in certain sort of setting much more often. Then the consequences and complications of that, and then how we can identify and quantify intraoperatively, and what do we do. Now, if you have a patient like this, Starr-Edwards valve that was put in 25 years earlier, and you end up with a paravalvular leak like that, this wasn't discovered on the operating table. This, obviously, the patient's been walking around with this because they didn't have echo at that time intraoperatively. I, by the way, have no disclosures. Now, I can point out that there are two very important publications that I've used in the preparation for this. There is not a lot around. If you search the literature, there are almost no publications on intraoperative assessment of paravalvular leaks. All the publications are on endocarditis, cardiology publications, and the breakdown of or the essence of suture lines. So we don't really have any information on paravalvular leaks discovered intraoperatively. But these are two good papers one can use as guidelines and some good recommendations on what we should do. So the first one on prosthetic valves of 2009. And interesting, there's one anesthetist in that group. And they don't say anything about intraoperative paravalvular leaks. Everything is about prosthetic valves and endocarditis and paravalvular leaks discovered afterwards. The second paper came out in 2011, and it's on transcatheter interventions. And interesting, there are no anesthetists involved on that panel. So when you see something like this, over the past 2 years, the numbers of publications have just exploded on paravalvular leaks. And why is that? Because everybody sort of performs TAVI procedures, percutaneous procedures. And where previously it wasn't even reported in the surgical and cardiology literature, suddenly there are over 200 publications over the past 2 years on paravalvular leaks. And this is a Edwards Sapien valve with quite a high velocity paravalvular leak. And I'm not going to say much about TAVIs and their complications. However, we know that the cardiologists in the cath lab accept much worse paravalvular leaks, and they see this as a victory, where a surgeon will be very disturbed to see this type of paravalvular leak if we come off bypass. But it is accepted in the cath lab much easier. Now, they say, if you look at the few papers published, between 5 and 20% of bioprosthetic or prosthetic and bioprosthetic valves may have paravalvular leaks and may be discovered intraoperatively. And between the mitral and the aortic valve, the two most common valve replacement procedures, it is more or less equal. But the question is this specific paravalvular leak that you see when you come off bypass, is it clinically significant? Is it going to make a difference? So we know that trivial or mild paravalvular leaks, no problem. We can accept that. But when it comes to moderate and to severe, and we have to remember there is no specific guideline on how to quantify this. We extrapolate from our aortic regurgitation and mitral regurgitation sort of advice, the guidelines on how to quantify this. So there are no real guidelines for this. And then we have to decide how severe is it and what are we going to do about it. So we must make a clear distinction between central or washing jets coming through the inside of the sewing ring, or jets real paravalvular jets going from the outside or around the sewing ring. So we talk about physiological jets or washing jets, the washing jets as we know it. And any paravalvular leak, by definition, is pathological and has to be sorted out or looked after. Now, if you look at this prosthesis and you see the washing jets there, this is inside. And it is, you train your eye and you get used to it. If you've seen it a few times, you make sure that there's nothing, there's no rocking of the valve and no dehiscence or rupture of a suture and no jet coming outside the sewing line. So we must make a clear distinction between central and paravalvular leaks. And they also, we must understand the way that surgeons, the technique they use to put in stentless valves, bioprosthetic valves, stented valves, and mechanical valves, okay, homografts also, because all of these, and depending on whether they replace the root and the ascending aorta, a paravalvular leak may occur or not occur. So, 2D, of course, when we come off, the first thing we look at is air and the filling of the ventricle. But there are certain predisposing factors that we may, which may guide us to preempt or to expect a paravalvular leak and to prevent it. This patient has got a tilting disc, single leaflet tilting disc, and so immediately you've got a lot of metal in the heart, and it's difficult to assess anything distal on the other side of that metal. So if you then look from all different angles and the outflow tract, then we can make our assessment with and without color. But do not just switch on the color. We first have a 2D picture and assess that way. Now, there are different reasons or causes, things that can lead to paravalvular leaks occurring. One is that there's a poor prosthesis choice. Now, you all work with different surgeons, and you know some surgeons are more so that they individualize their operation. They go for this specific patient, this specific valve is the best. Other surgeons we know are quite conservative, and they just put in any valve, one specific valve for one specific operation. They've got one type of aortic valve, and that's what they put in. And it's quite nice to work with surgeons who sort of think a little bit and make a plan and change the procedure and the approach and the prosthesis. So a poor prosthesis choice can lead to paravalvular leak. Incorrect sizing, and this is where the pre-op echo done by the intraoperatively, of course you want the patient assessed and fully examined before the operation, but we all know that intraoperatively the surgeon wants to see the picture and says, what is the size of the annulus? And if you get that wrong, then again, you may run into trouble. You may put in the wrong size. Now, they do also size the valve themselves, but remember that we see it in a dynamic way when the heart is moving while a surgeon sees a cardiopleged heart. The position of the valve, is it in the mitral, aortic position, maybe a supraannular implantation, and then something like that cannot always be predicted is a fracture or a rupture of a suture. Whether they use, what surgical technique they use. Is it sort of continuous sutures or individual separate sutures? All of this can contribute. When we assess intraoperatively, first of all, we must confirm that there is something. In this case, just next to, adjacent to the left coronary cusp, this aortic valve has got a jet. I would say probably 20-25% of your annular distance or circumference is your paravalvular leak there, where the left coronary artery comes off. And can't really say very much about this side, on the anterior side, because you're shadowing, acoustic shadowing due to the metal. So we have to confirm that there is a leak, first of all. Where is it? Will it make a difference to the patient? What is the mechanism of the leak? And we have to quantify it. Will the surgeon have to go back? Does he have to go back and do something about it, or can we accept it? And remember that we have to look at the whole patient. You've got a 90-year-old patient for aortic valve replacement, and you had a fairly difficult calcified annulus, and the surgeon took his time to to remove the original valve, it may be not so wise for a mild or mild to moderate paravalvular leak to go back and redo that. The patient may not cope with that second bypass run. So in the long axis, we see this. And it is just a suggestion on this side, on the anterior side. We didn't see it with a short axis view, but now we see the outflow tract, the valve itself opening and closing. There's a bit of turbulence across, the laminar flow in the outflow tract. And then during diastole, some suggestion that on the anterior side, there may be some leak. And in this specific case, the surgeon said, well, it was a very calcified annulus, and it took quite a while to remove all the calcium. And you can understand that. Not all patients are the same, and the tissue quality varies. The surgeon has to deal with. Now, I think 3D echo makes a huge difference, and it's also been shown in a few publications where people looked at paravalvular leaks and feel we can quantify much better with 3D and 3D, especially the Doppler color of 3D. And the reason being, you can pinpoint the specific origin, the specific pinhole of that paravalvular leak, just there where the left coronary artery comes off, on the sort of on the posterior, posterolateral side of that aortic annulus. But the beauty of the 3D image is that you can move it around and look at it from the outflow tract side. And again, you see now, identify a very high velocity jet coming from that little orifice. And the surgeon will say, usually they do, he will say, I did my best. I cannot do it better. It was a very difficult, the most difficult aortic valve replacement. They always say something like that. And then you have to believe them because they have tried their best. I don't know of a surgeon who wants this type of thing to happen. So they always try their best. And then you must decide, what are we going to do about it? Now, like I say, there are not many publications on this. Over the past 2 years, 1 or 2. And this is one of them that I came across, and where this group from Korea looked at a 12-year period, 54 patients, where they looked only at mild to moderate paravalvular leaks. And their endpoint, after they followed these patients up, and their endpoint was death, repeat surgery, or heart failure. Okay? And then they looked at 8-year event-free survival. And they found that in the aortic position, if this occurred in the aortic position, then 70% of the patients, plus minus 12, were event-free after 8 years. While in the mitral valve position, 16%, plus minus 8, were. So this is clinically very significant, statistically significant. So it means that we have to be much more aggressive with a paravalvular leak when it's in the mitral position. Okay? Aortic, you can accept. And it does make a bit of sense because in the mitral position, it's during systole that the leak occurs. So it's a very high velocity jet. The systolic force of that ventricle creates that turbulent flow across the opening, and therefore it is quite a high velocity jet. During aortic regurgitation, paravalvular leak, it's a lower pressure gradient. It's a diastolic pressure, and it happens during diastole. So it appears that we can be more conservative with aortic paravalvular leaks. Next paper from Toronto, and very interesting. They look at 400, and this came last year, retrospective sort of analysis, and the 442 patients, both aortic and mitral valves. And they found 53 patients with paravalvular leaks, and half aortic valve and mitral valve repairs. And they found that the mitral valve position is usually when you have a bioprosthetic valve, that it gives you problems, that you get the... And it can be a reason for that. It can be that the patients are older. Therefore, they put in bioprosthetic valve, more calcified annulus. That may be a good explanation for that. On the other hand, in the aortic valve position, it is often mechanical valve that leads to problems. And the calcification identified before the replacement can be seen as a risk factor, and you have to look more critically for paravalvular leaks afterwards. And of course, it goes without saying, the longer the bypass time, the more predictive it will predict paravalvular leaks, because the surgeon has more difficulty in taking out all the calcium and putting in the new one. And then one last point. When you have a paravalvular leak, it doesn't mean it causes sepsis or endocarditis, but it appears that it's associated with post-operative surgical sepsis afterwards. Again, it can be your weaker type patient, your older patient, your more frail patient. So a very interesting one, that. Now, when we see something like this, total dehiscence of a mitral annuloplasty band, we do not need any quantification techniques because we know this is torrential mitral valve regurgitation. Although the patient walked into the hospital and was asymptomatic, he had several weeks after his mitral valve repair, but total dehiscence of that annuloplasty ring. And this was then taken out. Now, if you search for parameters to test or to quantify paravalvular leaks, there aren't any. We have to use our regurgitant techniques, your aortic and mitral valve regurgitation quantification techniques, to assess and to quantify paravalvular leaks. So the vena contracta, the size, but remember, often this is not a round jet, a circular jet. This is very often sort of around the circumference of the annuloplasty band or valve replacement. I'm going to show you this case. It's a patient with previous endocarditis, prolapsing aortic valve there, almost destroyed, and the surgeon replaced it nicely with a bioprosthetic, stented bioprosthetic valve. Now, do not get confused with these are just the sinuses of Valsalva, and they have to be there because that is where, in diastole, the pressure builds up for the flow to go into the coronary arteries and to give your coronary perfusion. So again, even with 3D, it's quite difficult to see distal to your mechanical, your prosthesis, where obviously the ring is made out of metal, and it gives some artifact on that side. If you then look in your 2D picture with X-plane, again, there's acoustic shadowing anterior to that prosthesis, and you cannot really give an opinion. One thing I can say from that, it's maybe the light is in any form of echo pictures, the light is very bright, so it'll be nice if they can turn it down a little bit, because then people will be able to see the images better. But you cannot really give an opinion about the anterior side of this prosthesis. And again, in the short axis, the same. However, how severe is severe when you have a paravalvular leak, and shall we do something about it? Now, this is not a very severe paravalvular leak. However, there are a few characteristics there that I do not like when I see this type. First of all, it is eccentric, right diagonally across the outflow tract. So doesn't matter how bad it is, how severe it is, it's going the wrong way. I don't like that because it's going straight onto the anterior leaflet of the mitral valve. And we have, and you've probably also seen some patients like that, we have operated on patients with a perforation in the anterior leaflet of the mitral valve when this jet hits it for a month or 2 months or 6 months or a year. So there is a chance that this turbulent flow can cause damage on that side. So therefore, just the direction of this jet is not good enough. If you then zoom in and you look at it closer, sometimes you have to really search for it. In this case, the vena contracta is 3 millimeters. So this is not a hemodynamically significant paravalvular leak. Okay? There are other things that this can cause other type of damage. Either hemolysis, or it can cause endocarditis, and one must keep that in mind because the patient will easily come off bypass, go to the ICU, and out of the ward. However, what happens after a month, and surgeons don't like to see this, and so should we as echocardiographers also. And the vena contracta, 3 millimeters, so it is certainly not hemodynamically significant. With 3D, it demonstrates very nicely from the anterior side here, just where your right coronary artery comes off, diagonally across the outflow tract, and the same. So, how can we quantify that? One of a very sort of useful way of quantifying is, they say the proportion of this paravalvular leak, how much of the circumference of the stent or of the prosthesis does it make up? If it's less than 10%, then it's mild. 10 to 25%, moderate, and severe when it's more than 25%. Severe is usually quite easy to see and to decide to do something. Is this moderate one, this in-between one? But it doesn't mean that mild is innocent. With our Q-lab, you can really pinpoint it, get exactly to the orifice of that paravalvular leak. And in this case, I come up with a regurgitant orifice of 0.14 square centimeters, which is much less than you would expect for severe aortic or mitral regurgitation. So the effective regurgitant orifice area is overestimated, and we say that anything 0.5 centimeters square is severe. So in this case, this is not hemodynamically significant. It can cause hemodynamic, of course, and we have already excluded in this patient hemolysis and endocarditis. But then again, in the literature, there is absolutely no evidence that there's an increased risk of endocarditis with these patients. However, we know that absence of evidence is not always evidence of abscess. So the fact is, you cannot do trials on this type of thing. So if you don't see it, doesn't mean it doesn't cause it. Hemolysis, and when does a jet cause hemolysis? They say the higher the velocity, the more the chance that it will cause hemolysis. So if you've got a big paravalvular leak, it probably won't cause hemolysis. But with that, usually after 3 months or so, you find that the patient's HB drop. It may never pick up after the operation, but you become anemic, and there are different types of hematological parameters we can measure. Now, what do? We can either accept it, leave it as it is, we go back on bypass, and the surgeon must address it straight away, or we close up the patient and we pass it on to somebody else. One of those three. No other way out. So, very easy. If it's trivial or mild, we leave it, and we just accept it. If it's moderate to severe, we have to do something. The question is always that famous sort of confirmation from the surgeon. Don't worry, once you've given the protamine, the paravalvular leak will disappear. Now, does it happen like that? We don't know, actually. There is a chance that when you get endothelialization afterwards, so after a week or so, sort of organization and the prosthesis sort of finds its place in the aortic root or in the mitral annulus, that it may get less. So they may have a point. Protamine does appear to decrease the amount of paravalvular leaks. However, it doesn't stop it. So there's no science behind it. We just hope it works. So another case, and I'm almost done here, but the bicuspid aortic valve. This patient has had a moderate pressure gradient, and this patient actually afterwards, bicuspid valve, left-right orientation with the left coronary artery coming off there. And afterwards, actually, before the time, I've identified that there's very calcified anterior part and on that side of the annulus of this aortic valve. And I pointed it out to the surgeon. And he then, on 3D also, we saw it. Usually 3D does show up the calcium and the clumps of calcium quite nicely. And this is looking down from the aorta side onto the aortic valve. The beauty of this is that you can then turn it around and also look at it from the ventricular outflow tract side. And look at that, these chunks of calcium in the outflow tract. The surgeon then confirmed it on investigation when he opened up the root. He took out the valve and he said, this was the most difficult aortic valve replacement, so much calcium in this aortic valve. He put in a bioprosthetic valve because this patient was more than 70 years old, and this is what he was putting in, his choice. Then afterwards, it looked all right. However, if you really look carefully, you find that there is a tiny paravalvular leak on that side, and again, with your sort of color compare, a jet coming from the intra-atrial septum side across the outflow tract, and really less than optimal direction, although hemodynamically not a big one. With 3D, again, just confirms what we've got. The question is, do we accept it? There's the little hole. You see the little hole quite very, very well with the 3D modality. And in this specific case, the patient was elderly, it was long bypass run, long cross clamp, and we decided to leave it. And what happened to this patient? I don't know. I haven't followed him up, but this would be very interesting to know after 4 or 5 years, if he's still alive, what has happened to this. Now, we can also look at the mitral valve. And what is interesting, this specific patient is one of our mitral valve repair courses. And before the time, before the operation, we did notice a very, very calcified annulus. On that side, some rupture chordae, and this patient is going to, again, it's an elderly patient, but he's going to have a repair, and this calcified annulus. The surgeon then put in one of these physio rings, and afterwards I saw this. And when I pointed this out to him, and the remaining calcium there on the annulus, he said, yes, but it was very calcified. He didn't want to cause damage, so he put the annuloplasty band or ring almost onto the posterior leaflet rather than on the annulus. So it was very rigid. And you can have sympathy. It may be very complicated to put a suture through there. They don't want to damage the circumflex coronary artery or the coronary sinus or whatever, and therefore they picked it like that. The surgeon picked it like that. And then, lo and behold, a big paravalvular, or actually 2 jets going through. And again, the beauty is you can manipulate it and see that it's on the anterolateral part, and you can exactly point out where it is. Now we can decide, are we going back and put extra sutures? He said, no, I cannot do that. I've already tried, and it is basically like putting it into rock. So you just accept it. Okay, what do? We said we can accept it. We may go back onto bypass or address it. Sometimes we just close up and we pass it on to someone else, like in this case. And this is quite a topical sort of topic for, quite fashionable now for interventional cardiologists. They so wish they were surgeons because they really want to do all these things in the cath lab. And this is, again, a paravalvular leak after a repair, or a replacement. And on that side, just next to the prosthesis. And with 3D, it shows up quite nicely. Just be careful that you don't confuse artifact with the real opening. I suspect that is the dehiscence there, while this may be artifact. So your eye does get trained to that. A jet, quite a broad jet, elongated jet. It's not circular, and therefore it is hemodynamically quite significant. This patient had severe hemolysis one month after his valve replacement. And just to demonstrate with our 3D echo, we can see the catheters they put in, and then they nowadays absolutely love to close it off with these Amplatzer devices. And this is something that you see more and more happening. And yes, it is very good. It saves a critically ill or a sort of frail patient. It saves them a second operation. I'm going to finish off with this case, a patient after a stentless bioprosthetic aortic valve replacement. And there was a low afterload. The patient had arrhythmias and underfilled, and we came off bypass. But if you look carefully, you'd see 2 leaflets. This is like a homograft. It's without a stent. You see a right coronary cusp and a left coronary cusp. But you do not really see the the left coronary cusp. You see the non-coronary and the right coronary cusp. And then with your long axis, every sort of second or third beat, that leaflet does not close. And just an indication that we're on a balloon pump here is that there is no ECG connected. And the reason is that we saw this, that every second or third beat, as the heart fills and the peripheral vascular resistance changed, there would be or would not be aortic regurgitation. So the surgeon then, I must say this was his idea, and he very wisely said, well, I think the distal pressure, the peripheral vascular resistance is not high enough. We cannot generate enough pressure to close these leaflets because I've done a perfect operation and I cannot do it better. Okay? And look at this. Just with our echo Doppler, we see the severe aortic regurgitation. We put in a balloon pump, and lo and behold, it did close. So what I don't want to say here is put in a balloon pump after aortic, or when you've got aortic regurgitation. However, in a very special case, you can consider it. In this case, it closed the left coronary cusp, and the patient had no aortic regurgitation and good coaptation. Now, just to say that initially in 1996, with the original guidelines, valve replacement was a category 2 indication for TOE. And up till very recently, we still had surgeons who say, do not worry with the TOE probe, I'm going to replace the valve. Now, I don't think you can be further away from the truth, because we know now that in 2010, Dr. Tice and his group updated this, and they said, for adult patients without contraindications, TEE should be used in all open heart surgery and all thoracic aortic surgical procedures, and should be considered in CABG surgeries as well. Not only they, but also the European team with Dr. Flaschkamp and Dr. Fenech said that we concur that TOE is reasonable for the use in all adult patients who are undergoing either cardiac surgery or thoracic aortic surgery under general anesthesia. So I suspect in the future, as equipment becomes maybe more readily available and the skills people sort of train and understand it better, we're going to see it in all operations. So the take-home message here is that paravalvular leak is always pathological. Okay? It does seem to happen sort of equally in the mitral valve and the aortic valve position. However, in the mitral, it's usually a bioprosthetic valve. In the aortic, it's often a mechanical valve. Yeah. Then, if it's more than 20%, take up more than 20% of the circumference, it is severe. And we must always look at the patient as a whole. I mean, that goes without saying, and the older and the frailer the patient, of course, we have to. So the question is, shall we put TOE down the esophagus of every patient for valve surgery? And I certainly think so. I'm going to stop there.